Hello and welcome to your online lecture for assessing head and brain pathologies. I'm Dr. Cosby. So excited to be really venturing into kind of head and acute cervical spine pathologies. In the previous lectures, we talked a lot about C-spine pathology, which really aren't acute and for the most part aren't life-ending or life-threatening. Today, what we're actually going to do is really talk about those life-threatening emergent conditions, right? The reality is you're in the field of athletic training where you're going to be covering many contact sports, one of which is football, where there is an increased risk for the development of acute head and cervical spine pathologies. So your ability to manage those, your ability as you leave us and get ready to practice as a clinician to develop a clear plan of evaluation and management, i.e. an emergency action plan, will be extremely important in determining the outcome of the situation. And we can obviously think about Damar Hamlin as an example, that clinical staff's ability to call 911 immediately, to begin CPR right away, the medical staff at the hospital to be ready. Those are all practice events, things that didn't just fall together on that televised national level. Those healthcare practitioners probably had practiced that scenario over and over again. So as we move into more catastrophic pathologies, the one thing that I want you to be thinking about is, as a healthcare practitioner, currently as a student in the program, does my clinical site have an emergency action plan that's equipped to deal with a patient who has had an acute head or cervical spine pathology? And what does it look like? And am I prepared if it is the case that an athlete goes down? Do I know what it is? And then furthermore, as you get ready to leave us, do you have the ability to develop an emergency action plan at your clinical site that you'll get hired to? These are all important and reduce the threat to life-ending injuries, but we certainly know that acute trauma to the head and cervical spine can also have altering consequences or lifelong consequences that impact our patients. So this lecture is extremely important to me. So hopefully I do it well enough that you understand how to evaluate and assess a patient who comes to you or may not come to you, maybe unconscious with an acute head or brain injury. Our first stop is going to be in the area of bony anatomy, believe it or not. And this should really be a review, right? If you recall, when we were in the head and the face, we already reviewed this topic, but remember, the human skull itself is really going to form the foundation for our head, and it's what's responsible for encasing or protecting our brain. So these bones that you see here, a part of the neurocranium, they play a major role in the body's ability to truly protect the brain, right? So let's do a quick review, right? The cranium itself is composed of 8 bones. Those bones are known as the neurocranium, right? And those 8 bones, remember, if you recall, we have 2 temporal bones, so a set of temporal bones. And we also have a set of parietal bones. So these 2 bones have a right and a left component. We have the frontal bone, which is going to be the most anterior portion of the cranial bones. Then in the posterior aspect, we have the occipital bone. So right there, we already have 6 bones, right? So the 2 bones that are going to be left are going to be which 2 bones? Does anyone remember? Great. The sphenoid bone here and the ethmoid bone there. And so those are the 8 kind of cranial bones that really provide the bulk of protection to the brain itself. Now, there are other bones on the anterior aspect of the skull that also play a role in forming the shape of the skull, and so they should be mentioned and at least warrant mentioning. So the zygomatic bone is one of those, right? We can see that there. And then the maxilla is the other bone. In addition to that, we also have the nasal bones. If we were to kind of take the mandible off of this image, right? So if we were to take the mandible off of this image, flip the skull upside down, we'd be looking at the roof of the mouth or the palatine bone. So those are the major bones that are going to be responsible for supporting the brain the way that it needs to. Now that we understand which bones are kind of make up the actual skull, let's think about the skull as a whole. Like, I get really excited when I think of all that it's designed to do. So when we look at the skull, The skull itself is designed for maximum protection. And what is it protecting? The brain. So there are three ways in which the skull kind of works to dissipate force or slow down the transmissivity of forces that will go to the brain. That first way is with an external layer known as the skin or the scalp, right? We have a thick layer of scalp. If you dissected this in gross anatomy, you know that it takes a few scalpels to get through the actual scalp itself. So the scalp is going to be the first area of contact with the actual force, and it's going to absorb or dissipate most of the forces and hopefully do so in one amazing way. So this skull, as we can see here, is round, right? One of the things about round structures, at least, is that we know that if an object strikes a round structure, what's it going to do most often? Think about a ball hitting a rounded structure. It's going to reflect relatively quickly. So having this rounded anatomical shape is extremely important to force distribution or dissipation. And it's why, like, if we see in kids who are born with a more flat-like shaped skull, that we are intentional about putting that helmet on to ensure that their skull is more round-like so they can dissipate forces effectively. The third way in which we see that the skull works to protect the brain is in its thickness or its density. So the skull has some of the most dense bones in the human body. In other words, they're so thick that they absorb most of the forces being directed at the actual head. And so we have these three kind of anatomical structures, right? We have the scalp. Number two, we have the density. And then we have its shape, that rounded like structure. All of those different things are going to be extremely important in protecting the brain. They're all one, two, three, all going to work to really dissipate that force and protect the brain as much as it possibly can. So now that we've spent time talking about the bony anatomy, I kind of wanted to then progress to a layer deeper. So we have the bones, which are going to be protecting the brain. And then if we were to kind of take away each of the 8 cranial bones, we're looking at the internal portion just beneath the actual skull itself. So we're going to focus on this side of the PowerPoint for right now. And what we're going to be focusing in on are the brain meninges. And so the brain meninges consist of the dura mater, the arachnoid mater, and the pia mater. And we're going to dissect those just a little bit further. So that dura mater, it in terms of like Latin language, stands for thick or tough mother. So you can imagine that it is very strong, it's very protective, but it includes 2 different layers. The first layer is the periosteal layer, and then the second layer is called the meningeal layer. And believe it or not, they're named for what they actually do. The periosteal layer, remember, periosteum lines bones. So in this case, the periosteal layer is going to be lining the inner portion of the cranium, right? Or the dome of the cranium. So if you did a craniotomy in gross anatomy, when you kind of took the skull off, you would see the dura mater sticking to the top part of the skull, right? And then you have just deep to the periosteal layer, you have the meningeal layer. And that meningeal layer, as the name implies, actually houses a lot of the meninges and lives just below the periosteal layer. Within the dura mater itself, one of the beautiful things is that in between those 2 layers, we have the passage of veins and arteries, which are going to supply most of the blood to the brain. But then also what we see is we have the deoxygenated blood leaving the brain, and then we have cerebral spinal fluid kind of infiltrating those 2 layers. The next layer just below the dura mater is going to be the arachnoid mater, which is very thin, and arachnoid meaning spider. It's very web-like in terms of its layout, but it's a web-like layer of connective tissue. It doesn't contain any nerves or blood vessels, right? But this layer is extremely important because it is where most of the cerebral spinal fluid is housed. And if we think about cerebral spinal fluid, the most important role that it plays is it's going to provide cushion to the brain, but then also to the spinal cord, or another way to say that, it's going to provide most of the cushion to the central nervous system, which we'll talk about, I believe, on the next slide. So it will allow cerebral spinal fluid to circulate, and number one, remove any like impurities or invading pathogens within the brain and the spinal cord, but then also serves as a buffer for the brain and the spinal cord against any type of blow to those areas. The last and deepest layer is going to be the pia mater, which is a very thin membrane, and its major role is to actually hug the brain itself, right? And follow all of its contours. And so what we know about the pia mater is because it's so close to the brain that it houses a lot of the veins and arteries, which are directly responsible for supplying oxygenated blood flow to the brain itself. So again, what we can see here is another protective kind of mechanism to dissipate force before we actually travel to the brain, right? So let's review. 1, we have the shape, right? 2, we have the scalp. What was number 3? Someone tell me. So shape, scalp, and density. And now below all of those, we have these meninges, which are going to be more thick and dense at the most proximal portion, and then as we move deeper into the layers, they get thinner with the pia mater, which will hug the brain. So we can see we have so many different kind of layers or dissipating force anatomical structures that really are put in place to protect the brain as much as is possible. So now that we've looked at the bony anatomy, we've looked at the meningeal layers, and we've really looked at how force is dissipated, right? And how that rounded shape of the skull really helps to kind of reflect or deflect most of the forces coming through the skull to the brain. I think it's important to start actually looking at brain anatomy. So I'm going to zoom in just a tad bit. The brain itself can kind of be broken up into 3 components, right? Like at a high level, if we were to look at that, they could be broken up into 3 components. The yellow portion of this image is going to represent the cerebrum. And then if we look at the cerebrum at a higher level, we could say that the cerebrum is going to be broken up into lobes, right? That first lobe is going to be the frontal lobe, which is going to be more anterior, the parietal lobe, the temporal lobe, and then most posterior is the occipital lobe. And we'll talk about that a little bit later. But the cerebrum makes up a large component of the brain just in general. And so that's why we're going to spend more time talking about the function of the lobes in just a few seconds. But we have the cerebrum, and then we have in the most posterior aspect, probably lowest portion of the brain itself, we have the cerebellum. And so I'll point to that here, the cerebellum. And then last but definitely not least, I should say it that way, is the actual, what we would call is brain stem. And so the brain stem is going to consist of the midbrain, it's going to consist of the pons, and it's going to consist of the medulla, which would then be an extension of the actual spinal cord itself, right? So just for review, we have the cerebrum, which makes up a large area of the brain. We have the cerebellum, not to be confused with the cerebrum, which is going to be most posterior. And then we have the brainstem, which is really broken down into the midbrain, the pons, and the medulla oblongata, which again is an extension of the spinal cord itself. So let's break this down and dissect it just a little bit further, right? Because what we want to know is the structure and function of each of those anatomical structures, so that if we have an acute head injury, right? If we have that acute head injury, then one of the things that we have to be ready to do is to treat and care for that acute head injury. So let's start really with one of the smaller structures, but very complex structure, which is going to be the cerebellum. So that cerebellum is this image here. And its major role is what? What do you think? Great. Its major movement major focus is really to coordinate voluntary muscular movements, to maintain posture. Big thing that the cerebellum is known for is balance and equilibrium, or neuromuscular control and proprioception, right? So if we could think about that from this perspective, if we have an injury directly to the cerebellum, that patient might lack the ability to stand on one limb, might be uncoordinated in their movements, right? If we think about how large the cerebellum is, if you were to make a fist, it's about that large. Again, it's going to sit below the temporal bones and occipital lobes, so you can kind of see its position. It's just in a very beautiful position where it's really protected by the occipital bone itself, right? So major role of the cerebellum, if I could just repeat it for you all, it's very active in coordinating voluntary muscle movements, maintaining posture, but its biggest contribution really is to balance and equilibrium and or proprioception, right? So we've got the cerebellum down, we understand what its major role is. Now what we'll do is move to the actual brainstem and at least the components of the brainstem. As I mentioned, in the actual brainstem, we have the midbrain. So I'll point to it. We have the midbrain, we have the pons, and then we have the medulla oblongata. So I'll start with the midbrain first, and we'll talk through kind of its functions. The midbrain is probably one of the more complex structures within the actual brain because it has a range of like different neuronal clusters beyond the scope of this class. But when we think about its functions, its major function is the ability to hear movement or calculating responses and also being able to respond to environmental changes. So an example of that might actually be maybe the heater is on or the stove is on and you put your hand on there. If maybe the midbrain is compromised, you might not have that withdrawal reflex, if that makes sense. And then just below the midbrain is going to be the pons. The pons is, interestingly enough, is the site of origin for 4 of our 12 cranial nerves. So one of the things that I'm going to ask you if you want extra credit is to tell me what those 4 cranial nerves are. And I won't mention them here in the lecture, but if you want extra credit, tell me what those 4 cranial nerves are. But in general, because it's the origination site for 4 of the cranial nerves, its major role, like in terms of what it actually is in charge of, tear production, chewing, blinking, vision focus, balance, hearing, and facial expression. So there should be some hints as to kind of what it actually is. In addition to that, the pons is also known as a bridge because it serves to kind of link. You can see that here in this image. It's going to link the cerebellum to the actual brainstem. So we can see the cerebellum here, and we can see the relationship between the pons and the cerebellum. So we can see that there's like this direct bridge or link between the two anatomical structures, which will be extremely important in terms of connecting both the upper kind of portions of the CNS and then the lower portions of the CNS. And then the last structure involved, but definitely not least, is the medulla. So the medulla is going to be the bottom of the brainstem or represent the bottom of the brainstem, right? And so the most important thing about the medulla, as I mentioned, is it's where the brain kind of meets the spinal cord, right? The medulla of all the structures that I talked about is really essential for survival. Its major role is to kind of regulate many of our body activities, one of which includes heart rhythm, breathing, blood flow, oxygen and carbon dioxide levels, and recognizing when those actually change. And in addition to that, it also produces reflexive activities such as sneezing or vomiting or coughing or swallowing. So anytime you're having a sneezing attack, you can kind of blame your medulla, right? So you have those different actions that occur within the actual brainstem itself. So now for review, we've talked through the role of the cerebellum, right, which is mainly going to be balance, coordination, proprioception. We've talked through the different roles of the 3 different anatomical structures included in the actual brainstem itself. And so now what we really have to talk about is the largest structure in the brain, which is the cerebrum. And I've already said this, the cerebrum houses 4 different lobes that we're actually going to talk about. It is the largest part of the brain. Overall, if we were to kind of just kind of summarize what it does as a whole, it's going to initiate and coordinate movements, going to regulate temperature, and then other areas, right, which we'll talk about, are going to be responsible for speech and judgment, reasoning and thinking, etc., etc. So without further ado, let's take a look at the 4 different lobes and really truly talk through some of their functions, because I think that's extremely important for us to understand, especially in an injury model where if a patient has frontal lobe damage versus maybe parietal lobe damage or occipital lobe damage, you'll be able to kind of work through those just a little tiny bit. So that frontal lobe is the largest lobe of the brain. It's located at the front part of the head, and the frontal lobe is involved in personality characteristics, right? So think all of you sitting in the room have different personality characteristics. You can blame your frontal lobe for that. It's involved in decision making and movement. A big thing about the frontal lobe is Broca's area is located there. So oftentimes if we're seeing this speech component, Broca's area is associated with speech ability. So when a patient loses the ability to talk, loses the ability to connect sentences, most often there might be damage to Broca's area or Broca's area, depending on who you ask. And so it contains one of our pertinent speech centers. So in addition to decision making and movement, a big deal if a patient takes a blow to the anterior aspect of their head and maybe they're struggling through speech. One of the things that you're concerned with is if in fact there's injury to Broca's area. This happens a lot in patients with stroke. There might be damage to that Broca's area. The next lobe that we'll talk about is going to be the parietal lobe. So the parietal lobe is here. I'll erase that so we can just see the area. The parietal lobe is the most middle part of the brain. It helps the patient kind of identify objects and understand spatial relationships, or where one body is compared to another, or we could kind of say proprioception in some regard. The other thing that the parietal lobe is really good at doing is it's involved in interpreting pain and touch in the body. So lots of nociception, lots of mechanistic actions as well. You can also see that there is speech in this area as well, because it houses what is called Wernicke's area, which is an area of the brain that helps understand spoken language. So your ability to interpret what someone is saying to you, that is the area that is located in the parietal lobe. The occipital lobe is located in the posterior aspect of the brain, and it's most often associated with anything involved in vision. So being able to interpret what you're reading, being able to see at short distances or long distances, that is your occipital lobe. And then last but definitely not least, we have the temporal bone, which is going to be here, located on both sides of the brain. They're involved in short-term memory, also speech and musical rhythm. So if you have great rhythm, blame your temporal lobe. But then also they're responsible for auditory processing and or hearing. So we can see how all of these lobes kind of, work together, in other words, to kind of allow us the ability to stand upright, motor movement, to interpret speech, to see, to hear, to smell, all of those good things. And all of those are housed in the cerebrum, right? So in the largest portion of the actual brain itself. So I've been talking a lot about the central nervous system and the peripheral nervous system, but I guess we probably should actually define them. And I did this intentionally. So in terms of the nervous system, it can be divided into two major regions. You can see those two major regions here, the central nervous system and the peripheral nervous system, right? The central nervous system seems pretty straightforward. It houses two key anatomical structures, probably the most important vital organs in the entire human body, the brain and the spinal cord, right? And then you can think of the peripheral nervous system as housing everything else. So your 12 cranial nerves, your spinal nerves, and then the ganglia outside of the CNS, right? Now, we know that the spinal cord is responsible for doing what? Yeah, you said it, right? Transmitting information to the brain to kind of process, right? And then the brain is contained within the cranial cavity of the skull, and it's protected, right? The spinal cord itself is contained within the vertebral cavity and vertebral column, and it's protected by the spinous process and the vertebral bodies, right? So we know that the CNS system is really responsible for kind of processing everything that comes from the periphery, and then sending that information back to the periphery where we might have a motor contraction, for example. So that's the CNS. It's pretty simple, right? Composed of the brain, which we just spent a whole bunch of time talking about, and then also the spinal cord. Now, when we look at the peripheral nervous system, I'd like to spend more time there. It's named peripheral nervous system because it lives on the periphery, or another way to think about it is it's the one thing that lives beyond the brain and the spinal cord, right? So simple, but it really, if that's the way that you want to think about it, you totally can, right? The peripheral nervous system in particular has been called like the power plant of the nervous system, right? The brain and the spinal cord get all of the credit, but when we think about how complex the peripheral nervous system is, it's responsible for collecting information from our outside environment, whether that's touch, whether that's movement, whether that's a painful stimulus, right? It's going to collect all of that information, and it's going to send commands, or it's going to send information to the brain where it's interpreted, where the brain will then send it back, and it will then process and create or send commands. So we know that the brachial plexus is an example of this, right? The brachial plexus emanates off of the cervical spine and supplies the periphery. In particular, might supply the flexors, the extensors, the pronators, the supinators. So, right, anytime we do that, those motions are being sent to the brain where they're processed, and then movement actually happens. So a lot of what we do as humans really falls into the peripheral nervous system. Now, of course, if you have compromise to the CNS, the brain or the spinal cord, then most often you're going to also have compromise to the movements that might happen or how those are interpreted in the peripheral nervous system, and vice versa. If you have compromise to a nerve within the peripheral nervous system, the way in which we send signals might be delayed, right? Or might not happen at all. So those are the two different systems that we'll be thinking through as we think through injuries that can happen in the actual head itself. Now, let's talk through mechanisms of head injury, because that's going to be extremely important as we walk through our historical kind of questions to the patients that we're actually going to be working with. Our first stop is really with just appreciating what things can happen with movement, right? So we have two kind of mechanisms of direct injury which can cause or have been linked to what we call a cerebral contusion or a bruise to the brain. We have a coup injury and we have a contra coup injury. If we're thinking coup, what we're saying is a stationary skull is going to be hit by a moving object. An example of that might be your head is still, a bat hits your head. The moving object is going to be the bat. Stationary skull is going to be the stationary skull. Why is this important? Because it determines where, makes sense, where the injury is actually going to occur. So an example of this is if I get hit on the right side, my cerebral contusion is going to be on the right side. The opposite end of that, we have a contra coup, which means a moving head strikes a stationary object. So if we look at this image here on the slide, we can see this moving head is going to strike a wall, which is not going to move. Most often, the brain will move forward but rebound back, causing an injury on the opposite side of the skull, right, to the brain. Now, you might have a bone contusion here, but the actual cerebral contusion is going to occur to the movement opposite that. So those are things to keep in mind as your patient comes in with an acute head injury. So that would be acute. Now, what we are starting to see oftentimes there are sports that experience what we call a repeated subconcussive forces, right? Boxing, soccer. If we were to update the slide, we'd probably add in there maybe some MMA. And so then there's a potential that over time, because they've taken microtrauma after microtrauma after microtrauma, they might present to you with a head injury. And then we can have shearing forces across, most often going to be like that midbrain or the cerebellum, but we can have shearing forces that occur as a result of some type of sudden acceleration and deceleration moment. So we can see there are different mechanisms of injury. We've talked about the others as it relates to like a C-spine injury, but now we're talking about true brain injury. What are some ways that we can actually see injury to the cerebrum itself, to the midbrain, or to the cerebellum? Now that we've talked about the mechanism of injury, let's go ahead and progress through just a brief overview of assessing head injuries, and then I'll dive deeper at a different point in this actual lecture. So first, anytime we have a suspected head injury, we always want to rule out a life-threatening pathology first. And then once we've ruled out a life-threatening pathology, the next thing we're going to do is go into our assessment of the head injury. And it can be life-threatening, or it could be just a simple cervical injury, right? Big key thing is just making sure that we rule out any life-threatening injury before we progress in our actual patient evaluation. In fact, we know in terms of order of evaluation, life-threatening injuries have to be cared for first before we can actually begin the process of patient evaluation. So I kind of wanted to make that clear. There are really like 4 or 5 key things that we're going to be looking for or asking for in our historical checkup of the patient. Number 1, did they lose consciousness? Now, you'll learn over time that loss of consciousness actually doesn't occur in about 90% of the patients. So this may or may not be something that they explain. But if they say they didn't have a loss of consciousness, we shouldn't disregard that patient's head injury. We should still keep asking other questions. The next one we're going to ask is, do they have any disorientation? But the big one is going to be amnesia. And so we're going to talk about 2 forms, retro and antegrade amnesia, in just a while. But there typically are 2 types of amnesia that a patient will suffer from with a head injury, and these are the 2. And then we want to know, do they have any balance or motor coordination deficits, right? And if they do, then we're thinking cerebellum, right? Because that's the part of the brain that really is responsible for proprioception, balance, knowing where you are in space. Any cognitive deficits, then we're thinking, okay, maybe we have some issues with the cerebrum, right? Or one of the lobes within the cerebrum. And then, do they have any behavioral abnormalities, which have been linked to what we call is the neurometabolic cascade of a mild traumatic brain injury. And we'll talk a little bit more through that when we get to that slide. So as a review, I'm not going to go through all of these things again. Remember, the cerebrum is the largest part of the brain in terms of surface area, and it is going to include those 4 lobes, so the frontal, parietal, and temporal lobe. And as you can see, each of those lobes really is responsible for unique, key, distinct things. And this will become important as you are evaluating patients, right? All right, so that was a quick review. Let's move on to examination of specific head injuries. We are going to spend the majority of the time in this lecture on mild traumatic brain injuries in particular, and then I will do a separate lecture on more acute traumatic brain injuries, which are more life-threatening in nature. So let's talk through concussion or mild traumatic brain injury. I know that we're all aware that they exist. I'm sure that at some point in time, a definition or 2 or 3 has been defined or provided for you. But let's just talk through what it is. So an injury to the head, right, which most often occurs as a result of blunt trauma. Now, remember, we said the skull is dense. We said it's round. We said that it's covered externally by the scalp. And then we said, okay, deep to that, we have the meningeal layers, right? So blunt force trauma has to be high enough to dissipate through all of those key factors first. And then, or we can have some type of acceleration, deceleration force, right? Which causes damage to the brain and it causes a broad array of different deficits. So again, not every patient is going to present to you with all of the deficits that I'm going to mention, but it goes without saying that you should be assessing or looking for all of these things as you're asking history questions of a patient who presents to you with a head injury in your actual clinic. So first on the list is going to be any physical or somatic signs, right? So do they have a headache? Did they have altered levels of consciousness? Remember, I said oftentimes patients may not have a loss of consciousness. Do they have any amnesia, right? So those are all things that are linked to the physical part of the patient. And the next one's going to be, do they have cognitive impairment? So are they confused, disoriented? If they're trying to return back to play, do they have slower reaction times? Are they in a fog? Another thing that we have to think about is, do they have sleep disturbances, right? Because that is going to be indicative of really either hormonal changes or influx changes, right? So we want to make sure that whatever it is actually isn't chemically related, so they don't have this chemical imbalance. And then do they have behavioral issues such as irritability? That's going to be usually the number 1 sign and symptom following a head injury. And then last but not least, what emotional symptoms do they have? In other words, are they crying more often than they normally would? Are they sad? Are they down? Are they depressed, right? All of these things can certainly be associated with the head injury, particularly a mild traumatic brain injury, but certainly don't have to be, right? So I want to make that clear. If we were to define what an MTBI is, this is probably the gold standard in athletic training. We would say a trauma-induced alteration in mental status that may or may not involve a loss of consciousness. Again, 90% of patients who have an MTBI will not lose consciousness, right? And the reason we kind of live by this is because this is what the NATA, or the National Athletic Training Association, this is what they use to define a mild traumatic brain injury, right? There are other definitions that exist. This is the one that you most often will be tested on. Another way to think about a mild traumatic brain injury is as a concussion that is known as traumatically induced transient, which means they're going to get it back, disturbance of brain function. And it's going to involve a very complex pathophysiologic cascade, right? And we're going to talk about that neurometabolic cascade in a few slides. But on the next slide, what I want to give you are some stats, right? You know I'm key on epidemiology. So it's estimated that 300,000 sport-related traumatic brain injuries, most likely concussion, occur in the United States annually. So yeah, we're going to see this, right? The most common sports where we see this happening often, football and soccer. They're going to have the highest incidence rate. And then in high school and collegiate athletes, sports are second only to microvascular accident as a leading cause of traumatic brain injury. Growing evidence exists of a cumulative effect of mild traumatic brain injury. So in other words, not only do they suffer from this mild traumatic brain injury, but in addition to that, they suffer from neurocognitive impairments that can last longer than the actual insult of the injury. So it goes on to have long-term consequences, right? In high school athletes, the recovery is a little bit longer than the adult population, and we'll talk about why in just a second. And then we want to be careful with younger athletes because the risk of secondary impact syndrome is relatively high. So we want to be slower to return those particular patients to play when we can. As we move forward and we actually talk about the etiology of a mild traumatic brain injury, the pathophysiology of it is that there's this temporary biochemical changes that actually occur in the neurons at the synapses. So we take this direct blow to the skull, forces get transferred to the brain, and that disrupts neuronal function. And so then we have these acute symptoms of a concussion, which are largely a reflection of the functional disruption of neuronal action rather than structural. In other words, the brain isn't directly damaged. Most often, the signs and symptoms that a patient reports to us with are usually as a result of some type of damage to the neurons in particular. So what we're going to do is we're going to talk through something known as the neurometabolic cascade. And so we're going to do that, and it's going to be challenging to kind of walk through, but hey, exercise physiology, this is why it's so important in this program. So I'm going to talk through the pathophysiology of a mild traumatic brain injury. In other words, what things actually happen physiologically, right? Because we know that it's not really a structural injury or structural damage that causes the signs and symptoms associated with an actual head injury. And this is important to understand, because if you can understand this, I think it changes the way that you treat your patients in the first 7 days of a head injury, because you'll understand that there are biochemical processes that are occurring or that have been disrupted, and you need to allow your patient time to kind of create homeostasis, or at least the patient's body enough time to create homeostasis. So immediately after some sort of injury to the brain, essentially what we see is a disruption in brain physiology. In particular, one of the things that we see is this increased release of glutamate, which will bind to its receptor. And so when glutamate binds to the receptor, essentially what happens is we see an increase in potassium leaving the cell. So potassium will leave the cell and go into the extracellular matrix, and then we'll see an increase in the calcium going into the cell, right? So we have calcium going into the intracellular matrix, we have potassium leaving the cell and going into the extracellular matrix. And normally this would be okay as long as we have homeostasis. But in a head injury, what we typically see is a massive amount of potassium going into the extracellular matrix, which means we have a massive amount of calcium going into the intracellular matrix. Some researchers, if you really truly want to dive deep into this, have kind of said that too much calcium in a cell can be negative, and some even use the term like poisonous to the cell, right? So now that we have this disruption in sodium and potassium, one of the things that happens is that acutely, in an effort to restore the sodium potassium levels, the sodium potassium pump gets activated, right? And we know in the body in general that anytime a pump gets activated, it requires more energy, right? And that energy is going to be adenosine triphosphate, or ATP, right? So we have an injured brain, which probably doesn't even have the ability to provide enough energy in an injured state. We have potassium going into the extracellular space, calcium moving into the cell. And so the body automatically wants to restore that, right? It wants to get back to a normative state. So it activates the sodium potassium pump. And because of that, because it's requiring more energy, that in and of itself will trigger an increase in glucose metabolism. So now the brain is working overtime. An injured brain is working overtime to produce enough energy to supply the sodium potassium pump. In addition to that, we have this increase in glucose metabolism, right? And so we call this like a hypermetabolism. And the hard part of this is as all of this is going on, one of the things that we see is that cerebral blood flow is also diminished. Say what? So essentially what we see is that not only are we working overtime with glucose metabolism, but now we have this decline in the amount of blood flow in the actual brain. And so it triggers an energy crisis. The brain just doesn't know what to do, what to supply to restore homeostasis. And this energy crisis that I'm referring to, right, is it can last anywhere from 1 to 7 days. So it becomes important in those first 7 days of the injury to really allow that patient to rest. And these changes, that efflux of potassium into the extracellular space, that influx of calcium into the actual cell, the hypermetabolism of glucose, the increased need for ATP because the sodium potassium pump is working overtime, right? All of those things, and the decline in the amount of blood flow that we have flowing within the brain, those are all reasons that it becomes important to kind of rest the patient a little bit more, right? Because we want to allow the brain time to rest, right? To not require more energy than is already being required physiologically, so that we can reduce some of those acute signs and symptoms that we are seeing here. So oftentimes, when a patient has a headache, when a patient is reporting fog, for example, right? When a patient is stating they maybe have balance or motor deficits, most often it's not linked to the structural, like direct injury to the brain. It's linked to the fact that the brain is truly in an energy crisis and is trying to fight to bring all of the energy to the anatomical structure to help it restore homeostasis. And homeostasis within the brain, of course, is going to be extremely important. So now that you understand that, let's take a look at this image here. What I'm going to do is kind of maybe blow it up just a little bit, right? So we have glutamate being released. We'll start with point 1. We have glutamate being released right here, right? It's going to bind to its receptor. And so when glutamate does that, again, what we see is kind of the triggering of the release of potassium out of the cell into the extracellular space, and then you have calcium moving into the cell, right? One thing that I didn't mention, and this is just something that happens with injury in the brain, is we have this kind of impairment of neuronal communication, right? Remember, your neurons are going to be sending information to the brain, oftentimes, or electrical impulses to the brain. So we have these impulses being slowed down or delayed, which is why some people may be slower to respond, for example, may have decrease in reaction times as another example. And so we get this disruption of neuronal function. And then in addition to that disruption of neuronal function, the one thing that we can see here that makes us present with our signs and symptoms is going to be decreases in cerebral blood flow, changes in sodium potassium levels, which increase the need for ATP, all in the midst of a deprived blood flow or decreased blood flow as well. And so that brain is just struggling to get back to a normal state. So if I didn't say it well enough, I want to say it again. Rest is extremely important, right, for brain injured individuals. Number one, because it's already in an injury crisis. So anytime we make the brain think, anytime we make the brain work, that's going to require more energy, right? Resting, however, doesn't require energy, and that's what allows the brain to heal itself. And we'll talk about activities during mild traumatic brain injury and how the research is actually in favor of that. But for now, rest in those first few days is extremely important until the brain can return to a homeostatic state. So I'm not going to spend a whole bunch of time on this chart, but this is like my favorite chart when we're thinking about the brain, because it really tells you the signs and symptoms of a patient if they have some type of lobe or cerebellum or brainstem injury. So I'm not going to spend a whole bunch of time here. But let's say a patient has a damage to the parietal lobe. What are some things that they might have difficulty with? Difficulty reading, as you can see here, difficulty drawing objects, right? So this helps us determine like what things are we actually going to do. Difficulty with hand-eye coordination, so finger to nose would be a perfect test for that. We could look at the occipital lobe. Remember, that's going to be vision. So we're just going to test all of the visual fields. That's typically what we'll do. And then we could look at the cerebellum, and that's going to be balance. So lots of balance is what we're going to do there. The brainstem probably might be a little bit different, but one way that I usually do it in the clinical setting is just to have them drink something really quickly to see if they can swallow. They also might complain of dizziness or nauseousness. So if they do, then that's most often linked to brainstem injury. We could go temporal lobe. Remember, Wernicke's area is going to live there, so they might have difficulty kind of understanding what you're saying. They might have that short-term or long-term memory loss, so memory is being assessed in the temporal lobe. And then as we look at the frontal lobe, remember, a lot of that is going to be like processing, right? So loss of flexibility in thinking. So in other words, you can't ask really hard, difficult questions. They might not be able to ask those, right? Inability to focus on a task. And then we see a lot of the emotional components are linked to the frontal aspect of the brain. And so we can use this chart right here to kind of help us with special testing in the field in a patient who has a mild traumatic brain injury. So what are the signs and symptoms, right? As we think about it, there are a wide array of symptoms, and I'm hoping that you understand why now, knowing about the neurometabolic cascade, knowing that the brain is in an energy crisis. It's really going to depend on kind of how out of control the energy crisis is. But in general, the top maybe 8 signs and symptoms that have been reported are headache. That's probably the most common sign and symptom. That seems to be consistent in patients with mild traumatic brain injury. Again, we could go back to dizziness or lack of coordination and balance. Remember, that's going to be cerebella, so it's going to be lower on the brain stem. Nausea or vomiting. The blurred vision, most often associated with maybe like an occipital kind of pathology, right? So blurred vision, double vision, sensitivity to light. Confusion or disorientation, difficulty sleeping, no memory of the event, which would be retrograde, things that happened before, and then anterograde would be no memory of the event, so things that happen after, right? They may be irritable and have behavioral changes. Again, look at the lobes. That'll help you. All of these symptoms are related to lobes, right? Brief periods of diminished consciousness or unconsciousness. But again, a very poor predictor of recovery because, again, maybe 10% of those patients are going to actually lose consciousness. So how do we manage them? What are we doing in our clinical exam? First and foremost, we have to know the mechanism of the injury. Remember, we talked about coup, contra coup, accelerative, decelerative, right? All of those things will help you determine which lobe most often is going to be involved in the actual injury itself. So that's one key way in your history, your historical exam, to really truly get at what is going on with your actual patient. The other thing that we really want to ask over time is really about previous history of injury, right? One of the concerns with having a previous history is it increases the risk for subsequent concussions. It also increases the severity of the symptoms of the current condition sitting in front of you. But then more importantly, and probably for athletes at least more importantly, is it increases the recovery time, or another way to say it is it delays the recovery, right? So we really want to make sure that we're asking this wherever we possibly can. We really truly want to know what's going on with our patient. In terms of signs and symptoms, the big key thing that we want to do, we already went through the list, the large list of signs and symptoms here on this slide, right? But really what we want to get at here is, have we ruled out cervical pain, right? And C-spine involvement, right? Because in addition to the head trauma, you might also have cervical pain, which could also delay recovery or increase recovery times, depending on how you think about that. I've already talked about balance impairments or in coordination, but again, that's going to be linked to cerebellar complications. So we want to make sure that we're at least asking that historical question for sure. Loss of consciousness, remember, not going to occur in very many people. Want to ask about memory loss, so retrograde, any memory before, anterograde, which is any memory after. If they've had the head injury and then they come to see you later, what triggers the signs and symptoms? What are the relievers of the symptoms? And then last but not least, classroom activities of daily living affected, because what we're going to do is remove them from those things. We've had times where we'll remove a patient from, we're going to class because of the bright light or because thinking really increases or triggers those signs and symptoms. So other factors that will affect healing time. Some patients with learning disorders or psychiatric disorders, the age may also do that. Notice I've said age a couple times, but haven't talked about it. I'm going to talk about it relatively shortly. And then any history where there is mental health disorders are all linked to decreasing recovery or increasing recovery time. All right, essential components of the clinical exam. We need to do a baseline test. So in other words, any patient in a contact sport should have baseline testing done. And so we're going to have them do a SCAT. That's what that is. And they're going to have a baseline SCAT. And then we'll compare that SCAT to when they actually come into us. We're going to test motor control and balance. We're going to test mental status, neurocognitive testing, and visual testing. And we're going to kind of walk through each of these. So if it seems like I'm blowing through them, I promise I'm not. This is the graded symptom checklist. We'll do this in class, right? But what we're looking for really are any symptoms that fall into that 3 or above category, and how many of those symptoms do they have, and what are they linked to. If you look at this graded symptoms checklist, one thing that you'll see is that all of these are linked to different lobular concerns. That fog is really a key indicator, just to circle it. Fog is going to be a key indicator that the patient is actually in an energy crisis. So that would be something to actually look for. Now, I've mentioned retrograde and anterograde amnesia multiple times, but let's define them. Retrograde means before the injury occurred. So it can be long-term and or short-term, right? So this is an assessment of memory and orientation. So things that we want to ask: their name, their age, things that they're actually going to know. What day of the week is it? What game details that are before. So who are they playing? What's the quarter? What's the score? Anterograde is anything after the injury occurred. So how did they get to the field, or how did they get from the field to the clinic? Cognition, we can do word recall or number recall. At this point, I'm assuming you've all done some sort of SCAT, so you know we have both word and number recall, which can be very, very challenging, even for a healthy patient. So you're going to start simple and then work your way up to the more difficult to see how the brain can actually process that. So keep that in mind as we move forward. The next thing we're thinking about is, okay, we have a patient with an MTBI, but one thing that we want to make sure of is that they don't develop what we call as post-concussive syndrome. So these are unresolved signs and symptoms following a concussion, right? And so what would be the threshold for determining if someone has post-concussive syndrome? Good. If you said it varies, you'd be correct. But typically we can expect most symptoms of a concussion to last anywhere from 1 day to, 3 months. So anything outside of 3 months is considered abnormal. But the other thing that you want to use to determine if someone has post-concussive syndrome is to really look at the mechanism of injury and the extent of the injury, and to say, how long do we expect these symptoms to last? So when we think about post-concussive syndrome, like when you look it up, really the literature says anyone who has concussive symptoms longer than expected, right? Which isn't good criteria. But if a patient is reporting to you 3 months later with the same signs and symptoms and they haven't resolved themselves, then most likely they have post-concussive syndrome. The signs and symptoms are going to be exactly the same as those with a patient with a concussion, right? So persistent headaches, impaired memory, difficulty concentrating. These are the patients, to think about it this way, you start to see their grades decline, right? And so it can last weeks, months, up to years, depending on the extent of the actual head injury itself. So you just have to be very, very, very careful. In terms of management, return to play only when all of the symptoms have resolved themselves. And we can talk about this in class because I'm sure there are clinicians who kind of blur this line, but really the key risk is going to be to the development of secondary impact syndrome, which can lead to death. And so none of you want to be in that situation. At least I kind of hope you don't want to be. So let's talk about special tests that can be used to evaluate a concussion. You can do a neurological exam, which is going to be cerebral testing, right? So we'll do some cranial nerve testing, some cognitive testing, cerebellar testing, which will be balance, right? Sensory and reflex testing. In addition to that, we want to do eye function. So pearls are equal and reactive to light. We also want to do the H kind of test just to make sure eyes are moving the way they're supposed to. In terms of balance, Romberg's test and the balance error scoring system, which I will show you on the next page, and then coordination test, right? Cerebellum, finger to nose, heel to toe walking. You get a few different anatomical structures with those two tests. So here's the balance error scoring system. We get 1 point for each error. So hands are going to be on the hips. The patient's going to lift their limb up. You can see double stance first, single stance, and then tandem stance. And then you can challenge them by placing them on an Air X pad to challenge them even more. But essentially what you're looking for is in each of those positions, if the hand is lifted off of the iliac crest, if the eyes open because they're supposed to be closed, if they stumble or fall, if they move the hip into more than 30 degrees of flexion, if they remain out of testing position for more than 5 seconds, right? So all of these, you're going to count the number of errors. Scores greater than 25% or above compared to the baseline, right, is a clinically significant change or an increase of 3 errors or more compared to their baseline and you're concerned, right? So again, we have to have a baseline balance error scoring test first, right? The great thing about the BEST is it's a clinical test, and believe it or not, it is positively correlated with other more sophisticated tests that we're going to talk about on the next slide. So it's a good clinical tool to use in your assessment of patients following a head injury. The more sophisticated tools are the Sport Concussion Assessment Test or the SCAT-3, right, which is going to be a paper test. The Vestibular Ocular Motor Test, which is relatively new, and we'll do this in class. The iSync, which you can see here, and I think we actually use it at Point Loma. The King-Divic test, which is going to be more of a paper test. We'll do that in class. And then the impact test, which is a computerized test. Each of these allow you or afford you the ability to do a baseline test, which you most certainly should do with your patients over time. So let's talk through each of these just relatively quickly. The first one is the SCAT, Standardized Concussion Assessment Tool. It's the most widely adopted concussion assessment tool, probably because it can be downloaded on your phone and used that way, can be pulled up on a computer, so it's pretty versatile in that regards. It's a comprehensive tool that's going to cover all the domains of concussion evaluation. So we get the graded symptom checklist, right? We get the cognitive testing, which is word number recall. We have the BEST incorporated into that, and then we have that coordination exam where we have them put their finger on their nose multiple times. It's free. That's why it's widely used, and there are no extra testing supplies needed. So you could do this on the field. You could do it on the bus. I think the SCAT-5 has now, it's not SCAT-3 anymore, it's SCAT-5, but it should never be used as a standalone method to diagnose concussion, right? There should be other tools that we use in addition to this to help us, right? And it certainly should not be used to determine readiness to return to play. What we should be using are other sideline assessment tools, functional tools, taking an all-over comprehensive assessment. The VOMS is, as I alluded to, vestibular ocular motor screening test. It's going to test for balance, coordination, neuromuscular deficits, and really, I think you all have done this at least once, right? It can incite some very neurophysiological signs and symptoms. So may increase, specifically targeting the eyes and the ears. and the vestibular ocular motor system. So it's going to create dizziness, may make the patient throw up. But the great thing about the VOMS is it also has been used as a rehab tool, right? So it's an assessment tool and it's also a rehab tool. So for those reasons, it's gaining popularity among clinicians because they can use it not only as an assessment tool, but then take that assessment tool and create very sophisticated rehab programs for patients with MTBI. Great thing about the VOMS when you compare it to SCAT is it does not require a baseline. So interestingly enough, when we talk about recovery from a concussion, so I've talked a lot about youth, right? And I've said, they take longer to recover. They're at more of an increased risk. But I do want to stop here and really talk about youth athletes. So I'm going to spend a little bit of time here talking about youth athletes in particular. For those of you that want to work in the high school setting, this is for you, but really it's for any healthcare practitioner, right? So high school athletes tend to be more vulnerable to concussions than older athletes. And so there are multiple theories to suggest that. I'll give you a few and then I'll tell you kind of what Cosby thinks, right? Number one, it has to do with the fact that they have greater head to body ratio. In other words, their head is a little bit bigger than their body. In addition to that, their cranial bones tend to be a little bit thinner. So in other words, they just haven't developed fully and they're not as dense as adults' cranial bones are. And let's just be real. All of these things, a greater head to body ratio, thinner cranial bones, each of those increase the risk of injury because there's less protection, right? In other words, those forces that normally would get distributed or dissipated across an adult head most often don't and get carried to the brain. In addition to that, there are differences in the fitness level for high school athletes versus collegiate or adult athletes, right? So in other words, they may not be equipped to handle the neurometabolic cascade that's actually going to occur. In addition to that, the final thing that we would say is youth in general, they typically have weaker neck muscles than adults, which inhibits their ability to kind of dissipate forces that are going to be applied to the head, which increases the risk for concussion. But what I really like to spend a little bit of time with is that youth athletes typically have a more immature or developing brain. And for that reason alone, most often they cannot auto-regulate the brain's blood supply, and they can't manage the energy crisis as efficiently or as effectively as an adult can because they have an immature brain. So it becomes important to protect younger athletes because if not, their signs and symptoms may last a little bit longer. In fact, they typically do because of their inability to regulate the energy crisis that's happening. It takes their brain a little bit longer because their brain is just a little bit more immature than not. Finally, I want to end with this. This is an NATA infographic. This is extremely important. So we have patients who will have concussions and typically we'll send them home. This infographic was created for patient education. That is a key component to the rehab of a patient after a head injury. I don't think I can say that enough. In other words, we want to make sure that our patients are doing the work when they're not with us, right? So one of the things it starts with is, okay, let's prevent it, how to remain safe on the field. But if you have a concussion, what do? The first thing is this right here. Report the symptoms, right? Most high school athletes, most collegiate athletes, they don't want to report the symptoms, which is why we started to see the use of more sophisticated systems where we have kind of velocity markers being placed in the helmets to look at the amount of impact that's occurring and then pulling them based on the amount of impact, right? So we have these computerized systems which can track the force or the velocity of the actual hit. Want to make sure they get plenty of rest. Remember, we talked about the energy crisis. We don't need to increase that or lead to that. Give them time to recover. Take it slow at first and address any concerns. These ones right here are all linked, right? These ones right here are all linked. And the reason they're linked is because this has to do with the energy crisis, right? If we take it slow, if we allow them to rest, the brain can recover. Hopefully blood flow is restored and our patient can return to a normative state sooner rather than later. Okay, that concludes this lecture. So we've talked a lot about the anatomy. We've talked through mild traumatic brain injury. The next segment will be talking about traumatic life-threatening injuries.